So we're going to deal with nosebleeds. And I took a look at the last time we talked about this, and it's honestly been almost 2 years ago. So it's for you third years, you may or may not remember having this talk before, but the rest of you probably haven't had it. So I just want to go through some of the basics about taking care of folks that have nosebleeds, and we're going to do it in a case style. And I see like none of your videos, so I don't know if you're going to respond or not, but it would be great if you want to jump in and give some ideas and things, or maybe throw those on the chat and Dr. Wilson can pop in and let me know what those are showing, and then also she can let us know some of her experience taking care of these things as well. So hopefully it will be a good discussion. Dr. Tim has, oh, a prop? I can't, oh, he has an IED. Awesome. Wrong place, wrong insertion, but we will talk about things to insert into the nose. All right. So maybe we'll advance this slide. Here we go. Here's our first case. 76-year-old male coming in with a nosebleed for 2 hours. What kinds of things do you want to know, and what would you do right away?
See on blood thinners.
Right, you want to know the medication list, including blood thinners.
Take a tampo with their nose.
Don't be shy. You can unmute yourself and throw things out there.
Did you already mute it after you said it? That's unmuted. It's unmuted? Yeah.
Is it from one nair or both sides?
Right, exactly. And sometimes people will say it's from both sides, but then once you get things slowed down, you'll realize that it's just from one, and then what's been happening is it's running into the back of the nasopharynx and then coming out the anterior nair on the other side. But definitely want to ask them that. Sometimes you need to ask like if there was any kind of trauma that precipitated it. Some people won't tell you that there was trauma. You also need to know, like, does this happen regularly for you? Have you had any issues with it? Sometimes people will come in with a nasty nosebleed and won't tell you that like 2 days ago they were at ENT and had something cauterized or had a recent sinus surgery, or were just in the ED the week before for a rhino rocket or whatever. And so you just make sure that there's any history of that. Also, blood pressure issues. People who have hypertension are more likely to have higher rates of nose bleeding, especially when they're on some sort of thinners. And so what do you do right away?
ABCs.
Right, ABCs always. And sometimes even while you're talking to them, if you can tell they're breathing, they're talking to you, they're not cyanotic, you know, they've got good capillary refill, you've kind of done a quick assessment of those ABCs. And so you can try to put some pressure on it right away. And one thing you can use are these little fancy like nose clips. You can also just pinch the nose like this guy. But the thing is, what we do, we have a tendency to do is put those nose clips on, or we pinch the nose, and we only leave it on there for, you know, a couple of minutes, and then we just can't wait to check. So we take a look, and we take our fingers off or take the nose clip off, and we want to check. And you really need to leave it on there for a good 10 minutes to see, as long as it's not pouring out past wherever you're pressing. But if it's pouring out past wherever you're pressing, obviously you're going to have to do something else. But if it stops when you put pressure on it, then hold that for at least 10 minutes and try to get that nosebleed stopped. Also making sure in terms of our history, we want to look for any predisposing conditions. Like I said, have they had a recent nasal or sinus surgery or something like that? Do they have a history of a tumor that's a head and neck cancer? Any recent radiation or trauma? You know, sometimes it's so funny this time of year, people are always falling off their porch. It's really funny, like, oh, I tripped and fell off my porch. So a lot of older folks will be out like trying to get the newspaper, or watering their flowers on their porch, or sitting on the porch to watch people walk by or whatever, and then they fall off the porch. Sometimes they hit their face, and that can be an inciting incident for this type of condition. So you also want to look past medical history, like things that are worse by bleeding. Do they have, because if they have coronary disease and they bleed out and they get hypotensive, then that can be an issue. And then also, of course, a lot of those folks are already on blood thinners. And so finding out about that history. People who have cirrhosis, we know that they usually have thrombocytopenia. And so that can exacerbate any kind of bleeding that you have. And then renal disease can sometimes affect the clotting of the platelet cascade. Social history, smoking, of course, is a bad thing. It makes everything worse, including this. Nasal drug use. This is something that we sometimes forget to ask. I know sometimes I do. I'm like, oh yeah, I didn't ask if you actually put anything in your nose. And cocaine is obviously the one we think of, but a lot of drugs can be crushed and snorted. So make sure you're asking about any kind of nasal drug use. And then family history of coagulation disorders as well. Look at your medications. I know Kimmy mentioned this earlier, and a couple of you, looking at blood thinners, aspirin, warfarin, Plavix, some of the newer agents. Ask about those, of course. And then don't forget to ask about the medications that aren't always so obvious, which are NSAIDs, SSRIs, SNRIs, intranasal steroids. Those can make epistaxis worse. You also want to ask, of course, like you do with anything, timing, frequency, and severity. Is this the first time? Have you had lots of nosebleeds? And then always ask them how much blood is lost. And you realize that you're opening a bit of a can of worms when you're asking this question, because it's very difficult for some people to be able to determine how much blood is lost. We know that, and we know that when we estimate blood loss, even at a delivery, it's difficult for us at times. And so at home, a little bit of blood goes a long way. So people can tell you it looks like a bloodbath at home. And if they tell you that versus they tell you they were spitting constantly into a bowl or something, both of those things can actually be helpful in pieces of information. Then always ask if there's any associated symptoms. Is there vomiting? And a lot of times there will be, because blood makes the stomach very upset. And so they'll be vomiting quite frequently. Are they feeling dizzy or weak or lightheaded? And particularly, are they having chest pain from blood loss? So ask some of those associated symptoms. And again, you have to kind of do that all at the same time, because the main thing is you really want to get this bleeding stopped. So don't sit down in a corner with like a clipboard and start taking notes. You really sort of have to be acting at the same time that you're asking questions. So in this case, this person does have a history of atrial fibrillation and does take Eliquis and had a nosebleed earlier in the day, but managed to get it stopped at home with some pressure. And then this most recent one started about 2 hours ago, and he just couldn't get it stopped. His wife tried to help him get it stopped, and we just couldn't get it stopped. By the way, all these cases that I'm giving you are real cases that did present to the emergency department, or we're seeing like one of them is on a soccer field. So anyway, this person, no chest pain or shortness of breath, is definitely feeling a little anxious. And having a bad epistaxis is definitely anxiety provoking. So sometimes you end up needing to use a little bit of an anxiolytic with these people, because sometimes their blood pressure is elevated as well. And the anxiety medicine will help to bring that down and also help with the epistaxis control in that manner. So what do we want to take a look at when we examine this patient?
Their nose.
We want to look at their nose. Nothing gets past you, Dr. Tim.
I'm on top of it.
I know. I just hope you don't walk in there with an IUD. All right, yeah, we want to take a look at their nose. Of course, we want to look at their face and their posterior pharynx, things like that. So pay attention to those vital signs like Dr. Wilson was alluding to earlier. We got to look at those ABCs. How do they look physically? Sometimes they, like I said, they're anxious and sitting forward and things like that, because it's very disconcerting to have a nosebleed. But sometimes they look kind of crummy and they're pale and diaphoretic and stuff like that. So pay attention to how they look. Do a good examination of the nasal cavity. Do a brief evaluation of the mouth, nose, and throat. Look how much blood is in the back of the throat, whether or not you can see clots and things coming down the back. how much blood is on the gauze and towels and washcloths, because almost always they bring in a whole bunch of stuff they've been using at home. And then look at their skin. Pay attention for ecchymoses, because sometimes, you know, you may be picking up a bleeding disorder. Pay attention for petechiae. Again, looking for the thrombocytopenia, any purpura or telangiectasias, which sometimes, of course, you'll see with your cirrhosis patients. So get your patient ready for exam. They want to sit upright, sit them a little bit forward, kind of that classic sniffing position. You're going to cover them with like a pad or a gown or something to try to keep them as clean as possible. Most of the time they come in and their clothes that already have blood on them, but try to keep them clean. But also putting that covering helps you realize how much blood is coming out since you started seeing them. So it's about keeping them clean, but it's also helping you with your assessment by covering them with a pad, like a big chuck or a towel or something around their neck can be really helpful. Tell the patient not to swallow the blood, that they can interrupt your exam at any point in time if they need to spit out. So give them an emesis bag. Sometimes the basins, the big tubs, actually are more helpful, but sometimes the emesis bag is just fine. So give them something to spit in, and then make sure you have good lighting. This is where headlamps are super helpful. And then get your suction ready. And I put a picture here. This is a Fraser suction tip, and you can put that on the end of any suction tubing. But it's really nice to kind of get into the nasal cavity. Yeah, we already talked about the emesis bag. All right, so doing your nasal cavity exam, you want to anesthetize them if you can first. Sometimes we'll use like a little bit of topical epinephrine, a viscous, or lidocaine with epinephrine. Sometimes viscous lidocaine works too. Use Afrin, which is the oxymetazoline. Don't use the
happy for you.
Because you have reports of death when those are used intraoperatively. So you really want to try to use the Afrin, which is the oxymetazoline, as opposed to the phenylephrine. And that will help to vasoconstrict those vessels. So you want to try to get a good view. So use the use that Fraser suction. You can use a bayonet forceps, which I have here. To pull out clots. It's really good to pull out clots. And you can see how it's kind of curved here, and a very thin tips. And these are really nice to use in the nasal cavity. Sometimes you can have them gently blow their nose, but I would not have them do anything forceful because that can sometimes disrupt any clotting or tamponade that may already be starting, and then you'll be back to square one on that. You may need to use the nasal speculum, which I really like. It gives you a lot of good visualization. And you can, this is where if you use this and then your headlamp, you can actually see really well into the nasal cavity. But remember, the nose is very sensitive, so please put some sort of anesthetic in there. Pay attention to Kisselbach's plexus, and you can kind of see that right here. It's also known as Little's area, and you have to sometimes remove adherent clot. But just be careful not to, again, start things back up again. Look at that septum and the turbinates to see if you can identify source of bleeding. Sometimes you can, and sometimes there's just no way you can tell. But do a good exam if you can. And then here's just some pictures of the things I already showed you. All right, so this guy was kind of anxious and frustrated with the recurrent bleeding. He had a tendency to want to lay back into bed and really want to try to keep these people upright. His blood pressure, as you can tell, was a little bit elevated. The rest of his vitals looked pretty good. The skin was nice and warm and dry. It was well perfused. He wasn't diaphoretic or clammy or anything like that. And he did have no petechiae or purpura. And also notice that his heart rate was okay, so it's not like we were dealing with a rapid AFib or anything like that, particularly given his history of atrial fibrillation. Nasal cavity did have lots of clots in it, and his had a mildly deviated septum. So pulled out those clots with the bayonet, put some Afrin and lidocaine in there. The source did appear to be from the right side. And again, sometimes it's hard for patients to tell because they think it's from both. And it may be from both. But doing a good exam and a good history, sometimes you can identify that it's actually just from one. There wasn't any clear bleeding there at Kisselbach's plexus, but he did continue to bleed, so we couldn't identify the source at that point in time. So what do we do at this point? Okay.
Yeah.
Sure, we do the
Go ahead.
course, like we said. Sometimes the people need an IV, sometimes they need to be placed on a cardiac monitor because this is considered a hemorrhage, right? So if the hemorrhage is ongoing, you have to treat it just like any hemorrhage. And so sometimes you need the 2 large bore IVs and things like that, and make sure that you have a patent airway. Protect yourself. If we have learned nothing from COVID, which we've learned a lot, don't hear me wrong, but one of the things that we've learned is the importance of wearing our own personal protective equipment. So please make sure you have some sort of goggles and gown on and something that is protecting your face, and so that you don't get blood into your mouth or into your eyes. And if we're going to do labs, what labs should we do?
CBC, PT,
Yes.
PTT.
CBC, PT, PTT.
Maybe some liver functions.
Yeah, right. I love it. So we're going to get our coagulation studies. We're going to get our blood count because we want to know hemoglobin, right? Because we need to know where we're starting at, especially if they keep bleeding. And we also need to know what those platelets are. Sometimes white count can be helpful, usually not as much in the epistaxis world. And then, like Dr. Wilson said, we need our CMP because we need to see what our LFTs are. Because, you know, our cirrhotic patients, even those who aren't on any kind of anticoagulation, can have elevated INR and elevated LFTs. And then sometimes we need to type and screen or type and cross these folks. All right, so conservative measures, like we said, pressing on the nose. This is for anterior epistaxis. Sometimes cautery helps, sometimes nasal packing, and then sometimes thrombogenic agents. And so again, before we do any intervention, consider that need for pain medicine and or anxiolytic. Pressing the fingers, once the bleeding stops, you have to observe for 30 minutes. Again, keep that clip or your fingers are in place for 10 minutes before you reevaluate. If there's no recurrence, you don't have to do anything else. But I would have them use some sort like a Vaseline or a Bactroban or something just to coat that mucosa 3 times a day for the next 3 days to prevent rebleeding. Because Kisselbach's plexus is one of the most common areas for an anterior epistaxis. Rebleeding rates are very low in young people, but they are much higher, unfortunately, in our older folks because, again, they're on a lot of the medications that will increase their risk. And most of them also have some sort of blood pressure issue that increases their risk as well. And the next thing to do, if the conservative measure with pressure doesn't work, then you can cauterize. We most often use silver nitrate sticks. You can use a hyfricator if you're in the office or you have access to a hyfricator, but remember, it's very tender, so please anesthetize them before you use cautery. So you want to clear any of the active bleeding, use a little Afrin, start in the periphery and then move centrally. Just light touches with that silver nitrate stick to see if you can get the active oozing stopped. You do not want to over cauterize in this region because you're right there on that nasal septum and you can cause an ulcer or a perforation. And for the same reason, you don't want to do cautery on both sides. So if it is a bilateral bleed, you don't want to cauterize both sides on the same day. If cautery is successful, then the same kind of a deal. You apply that antibiotic ointment or Vaseline for 3 days. If you have to get to the nasal packing stage, which is not terribly uncommon, there are a variety of things that you can do. The first thing you can use is called a nasal tampon. Usually this is made of a type of foam and it's supposed to resist the growth of staph because of course we worry a little bit about toxic shock syndrome. This is supposed to resist the growth of that. So you, again, anesthetize, remember this part, and then also use the Afrin before sort of you do any of these steps. You coat the tampon with bacitracin, and then you insert along the nasal cavity floor. If the nary is large, then you can use 2 of them together. You can kind of squish them together and insert them both. Sometimes the bayonets are really helpful for this process as well. And then you drip saline kind of on the outside, about 10 mils, and then that helps to expand the tampon. So the tampon comes unexpanded. So you can see here in this picture, the flat, these are what they look like, and then this is what they swell to. So you can easily insert these tampons in. They go in very nicely. Just make sure you're going along the nasal floor and not up, but go along the nasal floor and they insert nicely. And you will probably have to deal with this at some point in your office, particularly if you practice in a rural setting. So just that's why this lecture hopefully will help you feel more comfortable with it. All right, so you can use this nasal packing, and I remember it was a really long time ago. I feel like maybe in med school or early residency, we did this, but I haven't seen this used in a long time because unless they're post-surgical, sometimes they'll do this in surgery, but I haven't seen this used in a long time, like acutely, because we have so many new advances to be able to handle anterior epistaxis. But you can use this gauze ribbon, and sometimes it is impregnated with stuff, and you can use your bayonets and put it inside and advance, and you sort of make this like a layer labyrinth of ribbon gauze, and then you just keep packing it in there until it's tight enough. Again, I don't think you're going to have to do this because there's so many advances, but I wanted you to know that this is an option. The balloon catheters are the ones that are most commonly used now. There's a Rapid Rhino, there's a Rhino Rocket, there's a variety of different brand names associated with them. But basically it's a balloon catheter and it's covered by this carboxymethylated cellulose, and it's like a mesh. And then once it expands, it works both by tamponade and also by thrombosis. So you have to soak it in sterile water. It cannot be sterile saline. I'm going to say that part again because it's very important to remember this. It has to be soaked in water, sterile water, not sterile saline, because the water is what activates the carboxymethylated cellulose, and it is not activated by saline. And so you have to activate it that way, and then you slide it in very much just like the nasal tampon. They come in a variety of lengths. Using the 5.5 centimeter one is the most common, and then you can use the 7.5 centimeter one, which has 2 ports to it for posterior bleeds, and I'll show you a picture of that. So you can see here, you're soaking your Rapid Rhino into the sterile water. You soak it for 30 seconds, and then again, you insert it along the nasal floor, and then you insert air into the Rapid Rhino. And then you kind of feel this little pilot cuff right here. And once that feels like kind of rounded, a little bit firm, then you know you've put enough air in. And so what happens, you can see with this one, is that you have the tampon being expanded. And so then you just tape it to the patient's face, and then you take it out. Usually, most people take it out at 48 hours. It says you can take it at 24 to 72. I think most people split the difference and have them take it out at about 48 hours. So if you put it in and it's in your office, then you can see them back in 2 days and remove it at that point in time. Remember, as you're removing it, you have to have supplies ready to reinsert or to handle a recurrent bleed if it didn't work. If patients have trouble and it doesn't work at home, then of course they should come back or give you a call or whatever. Usually I watch these people for a half hour or so after I put one in, just to make sure they're not going to have another bleed. And then by the time the paperwork's ready and they're leaving, it's usually at least 45 minutes since you've put it in. And so I think that's usually helpful. I don't know if you would do anything differently, Dr. Wilson.
My experience is it doesn't matter how long you watch them, they bleed in the parking lot. Yeah,
it's true. You could watch them for 6 hours and then they don't have anything, and then they walk back in and said, "Doc, it's bleeding again." But most of the time, you'll catch a bleed within the first hour. Except for the fact that Murphy's Law. I was like, what's the term I want for Murphy's Law? But in general, you should catch it within that first hour if it's going to keep going. Thrombogenic agents can be really helpful to have on hand. Most common ones you'll see are Surgicel and gel foam. And so you just use these agents, you kind of trim it to the right side and then put it directly on the area. Again, your bayonets are really helpful to be able to put it right on the area that's bleeding. You hold it in place for 1 minute and then it will affix to that area and promote thrombogenesis locally. There's some other ones that are available too, but I have never seen them used. I don't know if you have, Dr. Wilson, or any of you guys. Maybe you guys have seen this in the ER. I've only seen Surgicel and gel foam. Those are the most common.
I've seen Flow-Seal used once.
Okay, cool. Bovine-derived thrombin gel.
Mm-hmm.
That has good studies behind it. I've just never seen it used. All right, so if the persistent bleeding, any of these packing methods really do have a 90 to 95% success rate. So you really should get some good control with that. But if it's still bleeding, before you pull it out, try to pack the other side, because sometimes you get some tamponade from the other side and you can really have improvement that way. So you can just put a rhino rocket in the other side. Is the patient miserable at home with both sides of their nose like blacked? Absolutely, it's horrible. But at least they're not bleeding. And then make sure you get an ENT consult if they, particularly if they have persistent bleeding. Again, you should follow up in 24 to 48 hours. Usually take that packing out around 48 hours. You do want to rehydrate with some saline so that it doesn't stick to the sides of the mucosa and then cause any kind of clot to pull off and restart bleeding. If you read the literature on antibiotics, it's kind of controversial, but the emergency physicians as well as ENTs, they really prefer that patients be placed on an oral antibiotic, and it has to be something that's effective against staph. Doesn't have to be MRSA, but definitely has to be effective against staph. So usually what they send them home on is cephalexin, sometimes Clinda, sometimes Bactrim. Remember the cautions with Bactrim. And then usually treat them for 7 to 10 days. And they also recommend using a little bit of mupirocin at the nair as well. Again, toxic shock syndrome is rare, but is something to think about. Okay. We want to prevent recurrence, of course, so we want to keep the nasal mucosa moist. Sometimes these people come in the winter and everything is just bone dry, so you have to tell them to get a humidifier at home and hydrate the air in their home. Use some sort of topical antibiotic ointment or Vaseline in the nose. And then any kind of nasal sprays you want to direct away from the septum. So a lot of people are on, especially this time of year, are on Nasacort or Flonase or something, and if they're directing the nasal spray toward the septum, that's going to increase the risk of epistaxis associated with intranasal corticosteroids, and so you really want to direct that spray away from the septum. And so sometimes educating patients about that is important. Keep that blood pressure under control and keep it down. And then keep the blood levels of anticoagulants within the normal range, particularly we're talking about warfarin on that one. All right, and then blood pressure. You really need to focus on the acute management and not as much the blood pressure. But like I said, sometimes if you give them a little anxiolytic, that will help bring the blood pressure down too. And so thereby helps by default some of the bleeding. But you don't have to go aggressive with hydralazine or nitro drips or anything like that unless there's a concomitant issue that would warrant that. All right, so on this guy, we did not identify a source. We did not cauterize him. We did use a rapid rhino. He had great success, and he went home, and he didn't come back after he went to the parking lot. So we considered that a win. Okay, if we're worried about posterior bleeding, I just want to kind of go over some of the signs and symptoms that you might want to be aware of that would suggest posterior source. If it's bilateral, like Dr. Wilson was pointing out earlier, that's an important thing to note. If there's a lot of blood in the oropharynx and it's just kind of pouring down the back, that can increase your index of suspicion that this is a posterior bleed. If they're having a lot of vomiting of blood or coughing up blood, Or if, of course, they're bleeding despite your anterior nasal packing, and you've tried the contralateral side too and you're still bleeding, then you really should think that this is a posterior source. Thankfully, most bleeds are anterior, but think about posterior. There is this balloon catheter I was telling you about. It's like the Rapid Rhino or the Rhino Rocket, except for it has 2 balloons on it. And then there's 2 ports. And there's also, so this one is called the balloon catheter, but then there's also a Rapid Rhino, or Rhino Rocket that has like the 2 ports that looks very similar to this. Anyway, you insert the device until the posterior balloon catheter enters the posterior nasal cavity, and you can tell that by like where your ports are here next to the nose. And then you fill it up with saline and pull it forward until you can kind of feel that it's snug, and then you fill your anterior balloon. And they'll be marked on there which one's the posterior and which one's the anterior. Okay. I'm sorry, my daughter's home and she's calling me. Hello? Are you okay? Yes, I'm giving a lecture. Can I call you in a minute? Are you okay? Okay, love you. Bye. Okay, sorry. Okay. So, oh, you can also use a Foley catheter, and if you don't have access to one of those double balloons, and you can push that back into the posterior pharynx, same type of deal, inflate it, and then pull it forward so that it's snug, and then that's going to hopefully tampen out the bleeding. Okay. Posterior epistaxis does need to be admitted to the hospital for observation, and then you give them antibiotic prophylaxis very similar to before. If they have to be NPO, then of course just convert stuff to IV and get an ENT consult. All right, this is my next case. This is a 8-year-old little girl playing soccer, and then all of a sudden she had a nosebleed during practice. What do you think? What do you want to know?
Did she hit her nose?
Right. Especially when you're dealing with sports, right? You want to make sure whether or not somebody has been hit in the face or whatever. Anything else? Okay. Okay, sorry, there we go. Let's just go over a little bit nosebleeds in kids. They're rare in kids that are less than 2. If they're seen in the younger age group, you do have to evaluate for trauma and think about abuse, very similar to what Dr. Hibbard was talking about a few weeks ago. Also, you need to evaluate them for a serious illness like thrombocytopenia. Sometimes meningococcal disease will present that way, unfortunately. So think about serious illnesses and trauma if they're underneath 2. And then in general, though, older kids, any prior visits to ED for bleeding, so thinking about, like, do they have a bleeding diathesis or something that I'm missing? Is it bilateral or is it unilateral? And then nose picking. I love this because you don't ask kids if they pick their nose, that you say, which finger do you use to pick your nose? So anyway, that helps you to identify that, you know, of course, all kids pick their nose, so you just have to ask them that. Consider nasal foreign body as a source, particularly in your younger kids, like those 3-year-olds and even 2-year-olds, because they can be sticking stuff up in their nose. Also ask the associated questions about hearing loss, torticollis, trismus, not trismus, unilateral cervical adenopathy, ear pain, those types of things that might make you think of something a little rarer, like a tumor. Okay, so in this case, with this little girl playing soccer, she did not have a direct blow to her face, but good job asking her that, Dr. Steiner. She did not have a fall or an injury. She doesn't have a history of bruises or petechiae, and a quick review of her body did not reveal any of that. She's had all normal well visits and normal blood pressures in the past, no history of like pediatric hypertension, no history of headaches. She does have a history of allergic rhinitis, and she has been using Flonase regularly. And she had had some intermittent nosebleeds since they started using the Flonase. And of course, when mom is asked about it, she's like, oh yeah, she has had this ever since she started that nasal steroid. Interestingly enough, I took care of this kiddo. It was during one of my daughter's soccer games, and the grandma was just so upset with me because she really wanted. She said the way you treat nosebleeds is by laying the kid on the floor, on the ground, and then she propped the girl's legs up on the bench, the team bench, and she was just adamant that this is the way you treat a nosebleed. And so I had to tactfully discuss with grandma that really she needed to sit up because we didn't want gravity contributing to this nosebleed. So it was an interesting little dance that I did with grandma. But we got her upright and put some pressure on it, and she was fine. And then she followed up with her PCP and switched her nasal steroid, and she did fine. Okay, here's the third case. 45-year-old guy comes to the ED after an altercation with his brother. Complains of nosebleed. Also complains about his brother. He was complaining about his brother the whole time. I think his brother bothered him more than the nosebleed. So I think you guys already know the questions to ask. He's very upset. He was angry. Of course, he's accompanied by the law enforcement, and his vitals were fine, but he wasn't in any medical distress. He was in a lot of emotional distress. He smelled heavily of alcohol. He was holding his face, he was holding his nose, and there was a lot of blood on his hands and his clothing. And then, so once I finally got him calmed down enough to take a look at him, he did have a laceration over his nasal bridge, and he had bilateral involvement of the epistaxis. Did not appear to have a septal hematoma. He was not vomiting blood, did not have any cough at all, let alone hemoptysis, and he didn't have any chest pain or shortness of breath. This is not exactly the guy, but I found this picture on Google. This is very similar to the laceration that he had over his nasal bridge, and then also very similar to the amount of swelling that was present. So what do you think we should do next? Anyone?
I might CT his face, make sure he doesn't have a fracture.
Right. Yeah, exactly. Good job, Dr. Tim. And so it's a good thing you got the CT because you can see that he has a fracture, not one, but two fractures. And this is just exactly like what that guy that I took care of had, because his brother had beat him up. They were both drunk. So I talked to ENT on the phone and got him some follow-up. Most of these, the ENTs will have you go ahead and fix, but remember, you are sewing skin over a fracture, so you are closing an open fracture. The thing is, they usually can't fix them acutely because of all the swelling, so they like for the skin to go ahead and be closed, and then they can revise that during surgery. But they do want you to go ahead and fix it. Most of the time, but make sure you get them on the phone and talk to them about it. Bleeding was stopped with pressure. He was observed until he was calm and he was ambulating fine. And in this instance, of course, also I CT'd his head to make sure he didn't have any intracranial trauma. And then he went home on antibiotics. And then you, of course, do a really good thorough exam of the rest of his body too to make sure he doesn't have any other injuries. He did go home on antibiotics and had ENT follow-up, and then he eventually had an open reduction surgically. And then this is just the most recent Epistaxis algorithm. And it is from Up to Date. So there you go. Questions, thoughts, comments? Did anyone count any sheep during this lecture?
Dr. Bunch, I just wondered if you had any comments or suggestions. My experience is that people are pretty uncomfortable with their nasal packing and are always not very happy that they're going to go home with that in place. Typically, it's right around the time of family pictures and that sort of thing.
Right.
So is there anything that you do to like make it, like as far as the discomfort, you know, more tolerable? Like I'll try to deflate it a little bit, you know, so that it's not quite so tight perhaps, but anything else that you've done?
Yeah, no, I think that's the most important thing. Obviously, you can't send them home on NSAIDs, particularly if they are also on another agent. And then depending on how important that agent is, that's something we really didn't talk about. You may hold that for a day or two. If they just had an MI though and they have a fresh stent, then most cardiologists will want you to go ahead and continue it. Maybe you'll hold it for one day, but you need to continue it. And so that's why follow-up is so important, and for home instructions are so important. And then having them sleep upright actually does really help, because if they try to lay down with that packing in, it's more uncomfortable. So kind of creating a padding around their bed or sleeping in a recliner or something like that makes it more comfortable. Really the nasal ointment around it is also kind of soothing, because sometimes the external nary becomes irritated. There's not a lot you can do about the fact that you have a giant, you know, balloon in your nose. Sometimes if people are really anxious about it and they will tolerate small doses of an anxiolytic, even if it's just a small dose of a hydroxyzine or something, that will help them. And then also like Tylenol, or very low dose, like Norco or something. I hate tramadol. I think it's a very difficult drug. It is not clean at all. It has a lot of interactions with other medications, and plus it is serotonergic, and so it can also affect blood cascade. We can talk about why I hate it another day, but I never use tramadol in these instances. I don't know if you have any other words of wisdom, Dr. Wilson.
No, I think that's really, yeah, that's what kind of similar to what I would do. But the other thing I would say is if you get the person that comes in and you're able to stop the bleeding with like pressure and some Afrin and those sorts of things. Dr. Bunch was mentioning discharge instructions are really important. You want to make sure you tell these people not to blow their nose for at least, you know, like the ENTs will say for at least like 72 hours or something like that. Again, to just avoid disrupting any clot or anything like that.
Yeah, right. Good point. Okay. Well, if you have any other questions or you ever want to chat about it or you have a case, you could stop by, talk to either one of us. Taking care of a lot of bleeding noses. The other day, actually, it was interesting. Dr. Tim had a patient who had a nosebleed with an NG in place, and talked about whether or not we could put a rhino rocket in next to the NG. And my feeling was that it would be pretty hard to get a tamponade around that tube. So he did a good exam to look for any areas that may need cautery, and then used some Afrin and things like that, and made sure that she was upright and that her blood pressure was controlled. And I believe you were able to get it stopped with pressure, right, Dr. Tim? This was Dr. Church as well.
Yeah. I'm sorry. The patient.
It was you and Dr. Church, right?
Yes. Yeah, she was on heparin, had an NG placed traumatically in the ER and had a nosebleed. So we held the heparin for an hour for pressure and then Afrin, and it cleared up the nosebleed.
So I guess that's just a recent example of how you will definitely see this. It could be even on the inpatient side of things. All right. Well, you guys have a great day.